So hello and welcome to part 3 of our video. This video can be used as a standalone to help nursing staff understand the responsibilities related to documentation during a code blue resuscitation. So the code blue scenario that you have just watched does not follow this code blue charting. This is a standalone sheet. So I'm going to go through the 4 pages. So as you can see, our facility, St. John Regional Hospital, the date, time the code blue was called, and where the code blue is. I would like you to take note that the time the code blue was called and down here at the time BLS was started should coincide. There shouldn't be a long period of time from when you recognized the patient was down to when you initiated CPR. So you can notice in this example, code was called at 13:08 and basic life support was started at that time. You may also say, if you do not know the name of the person who BLS was initiated by, you can put floor RN, or you can just simply put RN or LPN. The initial assessment, this patient was an inpatient, and was it witnessed? Not all of our code blues are witnessed. Most of them are unwitnessed, and then that's okay. You'll tick the unwitnessed box. Many people struggle with, is this a respiratory or is this a cardiac arrest? Because if it was unwitnessed, you don't know. So you can check both because you don't know which happened first. Then we will move on to airway management. If this was a true code blue, it wouldn't be spontaneous respirations. You're never going to do mouth to mouth as a healthcare provider. That is not safe practice for you. You may possibly do mouth to mask as a protective component for yourself. There may be another method, but this patient was given a bag mask. So in the previous video, you would have witnessed Jenny Ingalls, the respiratory therapist, initiating her breaths using an oral pharyngeal airway and a bag mask. 100% oxygen was delivered through the AMBU bag or bag mask device. And then this patient also got intubated, and so endotracheal intubation. If you are a nurse working on the floor, either RN or LPN, this may not be a familiar procedure to you. The respiratory therapist would be expected to tell you the size of the endotracheal tube, and that could be, for an adult, it could be a 6, a 7, a 7.5, an 8, 8.5, or a 9. And they're also going to say how many centimeters, which means measuring from the lip line how far in this endotracheal tube is. So for example, they may say to you a number 8 at 22. So that would mean a number 8 endotracheal tube, 22 centimeters at the lip line. Chart the time that it was inserted, by whom, and you may have to follow up and figure out the person's name of the person who intubated. So you may have to ask them to stay around, or you may even have to page respiratory, because a patient may have gone to ICU by now and you are doing this in retrospect and you're maybe thinking, goodness, I don't know who that respiratory therapist was. I'll have to page them. If they are not there to obtain the signature, please do not worry about that. When an endotracheal tube is placed, you will see either the team leader or the person who has intubated auscultate the chest. You will also see them use a disposable colorimetric carbon dioxide detector. This is a single-use device that is placed at the end of an endotracheal tube, and this is done by the respiratory therapist. Electrical therapy, AED. If you had an AED on your unit, you would state when it was attached. Manual defibrillator, which is what is on the crash cart. So when the crash cart arrives, that is the manual defibrillator. In this facility, the St. John Regional Hospital, we use quick combo pads. We do not use paddles. And all of our defibrillators on our crash carts are biphasic, not monophasic. So we state monitoring began at what time? And then the initial rhythm. Is it VTAC, VFib, asystole, or PEA stands for pulseless electrical activity. If you are an RN or an LPN on the floor, you are not trained in rhythm interpretation, and so you will ask the person manning the defibrillator, what is that rhythm? Below is a summary of the number of times this patient was defibrillated. So at 13:10, the patient received 200 joules by the manual defibrillator. The RN, and it will always be an RN or a physician delivering the electricity, and what the result was. So this patient was shocked for either VTAC or VFib, because those are the two shockable rhythms. What was the result? There was no change in rhythm. The patient stayed in VFib. And you'll notice 13:10, 13:12, 13:14, and 13:16. Each of these shocks are delivered at 2-minute intervals. During the period between shocks, CPR is being administered. In this facility, we use the LifePak 20 defibrillator, and so it has an escalating energy protocol. So we start at 200 joules, the second shock is at 300 joules, and then all successive shocks after that are at 360 joules. So we turn to page 2. This is IV therapy. You can check if one is already present or if it was inserted. This patient had one that was infusing, but also at 13:24 had a new one initiated. 2 IV lines are ideal. Here is a summary of the medications that was given to this patient. As a floor nurse, RN, LPN, you may not be familiar with a lot of the code blue resuscitation drugs that we use. The one drug that all patients, regardless of their presenting rhythm, the one drug that all patients will receive is epinephrine, 1 milligram. And that can be repeated every 3 to 5 minutes. So as a recorder, your responsibility would be to look and say, okay, 13:11, first epi was given. I can give the next one at 13:14, so you can see the importance of having a watch or having a clock in your room can be. So this patient received epinephrine. He also received amiodarone, which is an antiarrhythmic drug. He received another epi, an additional epi, and now a sodium bicarbonate. The vital sign area, I suspect most of the time will be blank. You've arrived on the scene, the patient is not alive. Dead patients do not have vital signs. The only time that you may fill this out is post-resuscitation. You may have one set of vital signs there. Our defibrillators also have the ability to offer pacing. And so as a floor nurse, this may be very foreign to you. You may have to ask the defibrillation RN about this at the end of the code. Transcutaneous means external pacing. There will be a rate and there will be a number related to milliamps. You should try and remember to document the time, and then you could fill in the rate and the milliamps after the code is completed. The following at the bottom of page 2 is lab tests, and basically it just wants you to provide what you have sent. So in the previous scenario, we were not able to take blood from the IV line, so our resident put in an intraosseous needle device. That sits in the bone marrow. We sent it off to the lab, and the lab called us and informed us that they do not do blood examinations from bone marrow, routine laboratory work from bone marrow aspiration. So please remember, if your code team leader asks to have chemistry or hematology from that blood, that our lab does not process it. So you will have to take a venous or arterial sample and send that. The top of page 3 is a relatively new component to this document, and it is called Targeted Temperature Management Consideration. So following a successful cardiac arrest, if our patient were to remain comatose after what is referred to as ROSC, R-O-S-C. ROSC means return of spontaneous circulation. So if our patient remains comatose after ROSC, we may initiate targeted temperature management. It used to be called therapeutic hypothermia, to help prevent a secondary brain injury. This is the responsibility of the code team leader. The physician has to review the inclusion and exclusion criteria. But you as the recorder will have to prompt him or her to review this data. So inclusion is anyone greater than 18 years of age, a witnessed arrest with return of a perfusing rhythm, a Glasgow Coma scale of less than 9, systolic blood pressure greater than 90, but that's a very soft inclusion criteria. We may have vasopressors or fluid wide open. And a relatively short time between the patient being recognized as collapsed and to receiving advanced life support. To be honest, the exclusion criteria is very soft, and many of the patients that you will be reviewing will meet all the inclusion criteria. But again, this is a physician-initiated treatment modality. It is the recorder's responsibility to ask the physician to consider if the patient is a candidate. So then there is resuscitation summary, successful or unsuccessful. So if you were successful, you would be transferring this patient either to the intensive care unit, the coronary care unit. The next part is the recorder clock. So you need to assess the clock that you are using and the clock that is on the defibrillator, because you have charted over here on page 2. Oh, I'm sorry. You have charted here on the first page that you have shocked the patient at 1310 because you are using the clock in the room. You will have to look at the defibrillator because there is a time on the defibrillator. And you need to discern whether there is a difference in your clock and the defibrillator time. There rarely is, and many people will often use the little clock on the defibrillator as their go-to clock. The next column is who has been notified. So family, the attending physician has to be notified, and so does the family doctor. So this is not an option. You have to ensure that these physicians have been notified. Pastoral care may be at the discretion of the family. The coroner and post-mortem will be at the discretion of the physician. An organ retrieval will also be a discussion that the physician would have with the family. There is a small area here for notes, and to be honest, you don't have to chart as much as you think. So in the notes, at 1308, this patient was found unresponsive and pulseless. CPR was initiated and code blue was called. 1312, the respiratory therapist arrived to manage the airway. And then a total of 4 shocks with asystole being the end result. CPR given between shocks with Dr. Jack Brown stating good femoral output with compressions. 1330, Dr. Brown discussed situation with family, request to stop all resuscitation measures, time of death, 1330. So it doesn't have to be, you don't have to double chart. Like you wouldn't have to chart 1318, chemistry and hematology labs were sent. All of this is here. This is just anything over and above that you haven't previously documented. And then at the back, we are supposed to achieve signatures from all of these people who have attended. I'm here to tell you that there is great difficulty in that. Especially the team leader has probably gone with the patient to the intensive care unit and does not have time for you to achieve its signature. As long as you have the names here, a signature is a bonus. Rhythm strips. Because the integrity of our rhythm strips from the defibrillator deteriorates quite rapidly, if this patient was connected to a monitor already, then use the full disclosure that is on your unit. But if not, you would have, in this particular patient, you would have 4 strips because he was given 4 shock. Every time defibrillation is offered from the defibrillator, a rhythm strip will print out, and it will give you the pre, the shock, and the post rhythm. And so that's what you would attach here. If there were no paper in the defibrillator, if the defibrillator got turned off and you're unsure of how to attach the strips, please don't stress about that. Over here, you have stated that you have shocked the patient and the results from that. So if the rhythm strips are attached, that's wonderful. But do not overlap them. Less is better. So you may only have 1 rhythm strip. 1330, pronouncement of death. And that would certainly be acceptable because we know that over here, there are 2 rhythms that we shock, pulseless VTAC and VFib. And that documentation has been done already. Again, the integrity of the rhythm strips from the defibrillator does not last very long. So when you go back to review these charts a number of years later, the ink has disappeared. So if full disclosure is available, then that's wonderful. If not, then please don't stress about that. This brings us to the end of documentation. Documentation is a big responsibility and people often shy away from it. But I think they shy away from it because they are uncomfortable. This has been developed by the Code Blue Committee of the St. John Regional Hospital and is intended to assist the RN and LPN in managing the documentation related to a Code Blue. I thank you for your attention.